So we go to the next speaker, Professor Abhinav Sharma, who is the assistant professor in Division of Cardiology and Experimental Medicine from the McGill University, Montreal. He will talk about the emerging glucose-lowering therapies in type 2 diabetes. Please.
Thank you very much for the kind invitation to be here today. It gives me great pleasure to speak to all of you, and it was lovely to spend some time with you socially as well over dinner. If you get the slides up, that would be great. Perfect. So my name is Abhinav Sharma. I'm a heart failure cardiologist by background, although some of my research does intersect with diabetes. So I'll be talking about the emerging glucose-lowering therapies in type 2 diabetes, insights from the trial. I have an asterisk because I'll be shamelessly veering from this topic at many points, spending the first third of my talk ranting about heart failure. Then I'll dive into some of the clinical trials. And then in the end, I'm going to sneak in a couple slides actually talking about PPAR alpha pathways and heart failure prevention. May as well take advantage of all the experts in the room here. So this was the view from my house when I left with all the snow, and that's my fiance walking our dog, so it's very nice to be here in a rather warmer climate, I must say. Some disclosures. So I'll just talk about heart failure briefly as one of the forgotten outcomes in type 2 diabetes. Talk about the emergence of therapies that reduce CV risk, although Dr. Leila has kindly done all the heavy lifting for me, so I won't need to go into much detail. Looking at SGLT2 in heart failure and GLP-1 very briefly around atherothrombotic risk, but talking and focusing on the heart failure lens and potentially looking at some new data reflecting on the outcome of GLP-1 RAs in patients with heart failure itself. I'll touch on the new GIP GLP-1 RAs and focusing specifically on tirzepatide, given that there's the most data in that population, and talk about some future directions. So just looking at heart failure very briefly, of course, it affects more than 5 million adults in the United States, costing $30 billion annually. In Canada, it's a huge issue as well, costing $2.8 billion per year. In diabetes, of course, the prevalence is going to increase to 1 in 5 individuals. And so combined, diabetes and heart failure pose a formidable public health consequence and a formidable public health issue. And just briefly around heart failure terminology, because it seems to change every year, just to reflect, of course, you've got to have the clinical definition, which is symptoms and corroborated by natriuretic peptides or congestion. There needs to be a staging of heart failure where you go from at risk to pre-heart failure with stage B, so there's some structural changes, clinically apparent heart failure with stage C, and advanced heart failure with stage D, and the EF classification saying heart failure with reduced ejection fraction is when your EF is less than 40%. Now the terminology is heart failure with mildly reduced ejection fraction from 41 to 49, and heart failure with preserved ejection fraction with LVEF greater than 50%. And there's now this categorization of heart failure with improved ejection fraction as well, recognizing that there's a lot of patients with these new who've improved in their ejection fraction. And of course, the preserved population having lots of links with non-alcoholic steatohepatitis and NAFLD as well, which I won't really touch upon, but can be discussed in greater detail potentially later. And so back in 2014, an editorial describing heart failure as a cardiovascular outcome in diabetes that can no longer be ignored. And when we look at it from a historical perspective, looking at the intersection of diabetes and heart failure, it was initially described in 1972, post-mortem of 27 patients with diabetic glomerular sclerosis. 23 of these patients were excluded because of concomitant diseases. However, four patients that were left had LV hypertrophy and a cardiomegaly resembling primary cardiomyopathy, Chagas, or alcohol-induced cardiomyopathy. And so you have extensive fibrosis, extensive, of course, intramural calcification and fibrosis as well within the vessel wall. So this was initially described in 1972 here. And of course, when we look at US sort of epidemiologic data going back to 2009, and this has been replicated across multiple years, when we look at patients who are type 2 diabetes treated with insulin in large claims databases, the prevalence of heart failure and incident heart failure is actually higher than that of stroke and higher than that of myocardial infarction. This has been replicated in several other databases showing that heart failure by itself is a very important outcome within this patient population. And of course, as we've shown within databases from the Get With the Guidelines registry, diabetes is one of the most common comorbidities amongst patients with heart failure, and it's been increasing over time from 2005 to 2014, with almost half of the patients having type 2 diabetes with heart failure. And of course, if you already have type 2 diabetes compared to those without diabetes, your risk of heart failure increases irregardless of the presence of background diseases. So only with risk factors, atherosclerosis, or prior ischemic events, your risk for heart failure certainly goes up in the presence of diabetes. So this begs the question of, is this just comorbidities, or is there actually some sort of causal link between the two? And we've sort of argued that essentially, there's lots of mechanisms that are tying hypertension, coronary disease, renal disease to diabetes and heart failure, and all of these other mechanisms, including inflammation, fibrosis, triglyceride deposition, calcium handling, but it ultimately is very difficult to tease this apart. And we did a large-scale proteomic analysis several years ago trying to tease apart patients with diabetes and those without diabetes who have heart failure, describing that there's very, very extensive proteomic profiles that are different between these two populations, although I won't go into it in much detail at this point in time here. Just diving into more detail, Perry Austin, very interestingly, also came up within our analysis as well, reflecting on the previous discussion. So just briefly to take away that heart failure is an important outcome in these patient populations. There may be a direct mechanism of myocardial damage, and it may not just be a confluence of comorbidities, and certainly we see a lot of inflammation within these diabetic patients who eventually develop heart failure. Just talking about a few slides about UACR, since it was mentioned in the prior discussion. Very elegantly, it's been shown in epidemiologic studies that UACR is one of the strongest predictors of heart failure development in large-scale populations. From 2019, a large population study in the US showing that UACR, of course, greater than 300, and with declining EGFR, is one of the strongest sort of markers of incident heart failure. And an analysis by Berg and colleagues from the Brigham developed a risk score to predict heart failure in patients with diabetes using data from various clinical trials. And sorry, the font's a little bit small here, but essentially you get a number of points. If you're diabetic, you sort of add up the points based on the comorbidities. And I'll highlight that, of course, a prior history of heart failure gives you 2 points. But if you have UACR greater than 300, it also gives you 2 points, suggesting that elevated UACR is essentially equivalent to a risk of having a previous history of heart failure. And we validated this in several other databases, including the ACCORD trial and the EXAMINE trial, highlighting, of course, the importance of UACR as a prognostic marker for patients in terms of developing heart failure. We also did some machine learning analysis using data from the EMPA-REG outcome trial, where we took a variety of baseline characteristics and identified 3 distinct clinical phenotypes. We ended up demonstrating that amongst patients with type 2 diabetes in the EMPA-REG outcome trial, participants were clustered essentially using a data agnostic approach. And very interestingly, one of the clusters came out as individuals with very high UACR who tended to be older in comparison to, let's say, phenotype number 1, who are more likely to be Asian and younger. We found that this phenotype group 3 had the highest risk of development of heart failure. And we subsequently validated this finding and published this last year within the TCOS trial and EXCEL trial, showing that clusters that have high proportion of individuals with elevated UACR have the highest risk for hospitalization of heart failure. So just a brief takeaway here was that UACR has a strong prognostic association for heart failure risk in patients with T2DM. This has been demonstrated across multiple clinical scenarios and irregardless of the presence of baseline comorbidities. And this brings about the question around the role of microvascular disease in the development of heart failure and T2DM as well. So let's dive into some of the clinical trials, and I'll be rather brief here because a lot of this was already discussed over the previous two talks. So, of course, there's been an explosion in clinical trials that has arisen as a result of the 2008 FDA guidance that has come up. And now we're seeing the results of a number of these trials being reported over the past few years. And of course, this all started in 2007 when Steve Nissen demonstrated in a meta-analysis or suggested that there was a excess risk of myocardial infarction. And so, of course, the US FDA initiated their 2008 guidelines, which indicated that outcome trials must exclude a hazard of 1.8 in pre-approval and 1.3 in post-approval. And these participants had to be elderly with some CV disease, duration has to be several years, and there were several other criteria that were recommended by the US FDA. Apologize for this formatting here, but the relationship between diabetes and cardiovascular disease was traditionally atherosclerotic. Very interestingly, heart failure was rather ignored even by this guidance, and there was two major issues because of heart failure risk due to anti-hyperglycemic therapies, which now have been understood by TZDs and also with saxagliptin, and the safety of these therapies in patients with heart failure. And so when we took a look actually at all of the heart failure trials that were done previously, in fact, 1/3 of these didn't even have a heart failure definition back in the day. So this, I'm reflecting on talk earlier showing that PAD was often ignored as an outcome and without standard definitions as well. It's the same thing for heart failure. And so the heart failure definitions have been changing over time because of the increasing recognition of this important outcome. And in fact, very interestingly, when we looked at the meta-analysis that did not include the new SGLT2 inhibitors, we see that actually the signal for heart failure went the other way, focusing on favoring standard of care as compared to glucose lowering versus major adverse events tended to favor glucose lowering. So in fact, these signals of heart failure risk were already seen in a number of older trials, but it wasn't emphasized. And so why is this important? Of course, when we looked at the causes of death in patients with type 2 diabetes, such as within the TCOAST trial, of course, the vast majority of patients died from cardiovascular disease. But when we deep dive a little bit, interestingly, sudden death was the most common cause of death in this population, followed by acute MI and stroke. And then heart failure death actually came as number 3 in terms of the 3rd most common cause of death. Now, this is adjudicated clinical trial data and, of course, has its limitations. And so we also saw this actually if you have developed heart failure already within the, we published this in JACC Asia, looking at the Asian HF registry, that the vast majority of patients will die of cardiovascular disease. And when you break it down, most of these deaths tended to be sudden death or heart failure. So certainly as we progress, heart failure death becomes more and more relevant. And very interestingly, there seems to be differential risk depending upon where you're coming from. So patients who are from Japan and Korea seem to have the highest heart failure risk or heart failure death risk overall. Now, reemergence of heart failure really came about with some of the DPP-4 inhibitors, and I won't go into this in much detail, but remember that the trials for MACE outcomes were neutral. However, when we look at SAVOR-TIMI, which randomized 16,500 people to saxagliptin or placebo, the heart failure risk was substantially increased at 27%. And a meta-analysis of heart failure outcomes showed a slightly increased risk for SAVOR-TIMI and even an increased risk within the EXAMINE trial, although not significant. And this ended up leading to a black box warning for DPP-4 inhibitors, saxagliptin, and alogliptin. So we see TZDs with increased risk of heart failure. Now we see DPP-4 inhibitors with increased risk for heart failure as well. So certainly reflecting on us to keep this as a very important outcome overall. Now, SGLT2 inhibitors, I'm going to zoom through these slides because they've been very adequately covered. Sorry, I'm not sure why the formatting here is been shifted. But of course, SGLT2 within the proximal tubule and SGLT1 sort of a little bit more distally. Several, of course, clinical trials now. We've all discussed these in extensive detail, so I won't go into it in much focus. But really starting with EMPA-REG showing a 14% relative risk reduction and 3-point MACE, and overall outcomes being driven by a 35% risk reduction in heart failure. And when we look at the CANVAS trial here, focusing on the heart failure outcome, which seemed to be very, very striking overall, and Of course, when we deep dive into it a little bit more, showing that those with a history of heart failure seem to have the most benefit within this study. Dapagliflozin and cardiovascular outcomes in type 2 diabetes as well, showing that overall cardiovascular death or heart failure hospitalization was reduced, but MACE was not necessarily reduced. Looking, of course, at the other outcomes which have been described in more detail as well. So really impressive results for heart failure which have been described. And of course, just drawing attention to this hospitalization for heart failure signal here in comparison to some of the other outcomes. And of course, dapagliflozin in terms of heart failure for the DECLARE trial was one of the few that actually captured whether patients had reduced or preserved ejection fraction in at least some of the patients. And overall, demonstrating that those with reduced ejection fraction seem to have more of a signal of benefit within the diabetic population. And of course, we see then additional clinical trials that were done amongst patients with type 2 diabetes and nephropathy. So, of course, this was published in 2019 here. Again, super small font. I don't need to go into it in a lot of detail. But again, demonstrating this risk reduction of heart failure consistently across a variety of these trials. And then, of course, there's the SGLT1 and 2 inhibition, which we've already talked about in the previous study. So it saves me a lot of trouble here. But SGLT1, of course, is within, distributed throughout the intestine here, resulting in delayed glucose absorption, increase in GLP-1, and delayed glucose absorption in the colon. But as previously mentioned, socially may be a little bit unacceptable if you've got glucose sort of going through your colon at all times there. And so, of course, we have the SOLOIST worsening heart failure trial demonstrating that sotagliflozin, which was randomized in 1,200 patients with type 2 diabetes, substantially reduced the risk of death from cardiovascular cause and worsening heart failure. Again, I'm going through this a bit fast because we've already seen these slides here. And then, of course, sotagliflozin in patients with diabetes and chronic kidney disease in the SCORED study, also demonstrating amongst type 2 diabetes with chronic kidney disease, irregardless of the degree of albuminuria, which is actually quite important, randomizing more than 10,500 participants, showing a reduction in the risk of the primary endpoint of cardiovascular causes of death, hospitalization for heart failure, or urgent heart failure visits. So the takeaway points for SGLT2 inhibitors here is, of course, that amongst patients with established CV disease and multiple risk factors, there's a heart failure reduction. MACE, though, seems to be localized to the secondary prevention population, but of course there are issues with primary and secondary definition here. When we jump into the GLP-1 receptor agonists, of course, again, I'm not going to go through in a lot of detail, but highlighting the heart rate issue with GLP-1. So let's just, I want you to keep that in mind as we zoom through here. Of course, multiple trials, which we've all talked about in the last few sessions. Meta-analyses showing reduction in 3-point MACE, cardiovascular death, fatal, non-fatal MI, stroke. So all great signs for GLP-1 RA. All-cause mortality as well. Now, very curiously, the heart failure outcomes seem to be reduced in meta-analyses, although not seen in the individual trials very clearly, but an 11% reduction in the risk in the heart failure population, which is rather curious overall. But there may be some emerging issues with adverse outcomes in patients with type 2 diabetes and heart failure relating to GLP-1 receptor agonists. So what do I mean by that? Well, this trial was done, published in 2016, looking at liraglutide amongst patients with advanced heart failure. So those patients with reduced ejection fraction who are recently discharged from hospital. So a high-risk population overall. And the hypothesis was that liraglutide would reduce a composite global rank outcome, which included things such as rehospitalization, NT-proBNP, from baseline to 180 days. So EF was less than 40%, and this randomized around 300 patients. Overall, the trial with this global rank score was neutral, showing that, of course, liraglutide did not reduce this overall risk. However, we also demonstrated that liraglutide substantially reduced weight, which is what we expect within this heart failure population. So there was significant reduction in weight overall. A1C was reduced, which is fantastic. Triglycerides were reduced, which is absolutely great. All good things. However, when we look at the subgroup of patients with the diabetes in this population, a trend towards increasing risk, okay, of death or rehospitalization for heart failure. So already an emerging signal of harm with GLP-1s in this particular patient population. We subsequently reanalyzed this trial data, looking across the entire database and looking at total heart failure hospitalizations or death, and you could see an early separation of curves. And when we look at total events of interest, which included arrhythmias, there was a substantial and significant 35% increase in risk of total cardiovascular events and a trend towards increased risk of around 29% for heart failure hospitalization and death. So a new signal which we just published last year is demonstrating this potential risk. When we look at subgroups, of course, highlighted yesterday, you got to be careful with subgroup analyses. All trends, regardless of the subgroup, pointed towards increased risk of heart failure hospitalization or death within this population. And when we look at arrhythmic events, we see increased risk of arrhythmic events associated with liraglutide. So this really highlights the challenges in using these glucose-lowering therapies in heart failure populations. So what are some of the possible explanations? Well, is there a cachexia risk in HFrEF? We know that GLP-1 RAs reduce satiety, they reduce oral intake, so are we inducing a cachectic state amongst patients who are already metabolically very cachectic? Could it be that we're activating sinoatrial nodes in heart rate, which is mediated through the CCAMP-dependent pathway, and in a HFrEF population that may not be a good thing, so we have to be careful about that. And so more studies will need to be done, and I think within prior and upcoming studies looking at these dual pathways, inhibitors or agonists, reflecting on their safety within a HFrEF population is going to be very critical. We also did a post-hoc analysis of the Harmony outcome trial, which randomized a GLP-1 albiglutide versus placebo, and we demonstrated that despite the fact that there was reductions in the risk of cardiovascular events, when you look at the heart failure population, that risk appears to be ameliorated. You don't actually see benefits within that population, very curiously. And we subsequently done a meta-analysis of all of these trials, focusing on the heart failure population. And this was published very recently here, showing that when you look at the heart failure group amongst patients with GLP-1 receptor agonists, actually the benefits seem to be really attenuated, and you don't tend to see the overall benefit that you see in the full population. So it looks like there's some sort of differential impact of GLP-1 or risk of outcomes that are occurring within a heart failure population. So the takeaway here is, of course, GLP-1 receptor agonists have significant risk reduction for atherothrombotic events. The reduction in benefit in GLP-1 RA has been seen in our meta-analyses for patients with heart failure. And this question of possible harm signals has arisen as well amongst patients with established heart failure and reduced EF. This needs to be explored in future studies. Now, what are some of the upcoming trials here? Well, there's ongoing trials of GLP-1 RA in patients with heart failure and preserved ejection fraction. So this is a very different phenotype of individuals where heart rate and modulation of heart rate does not appear to be as critical in this population. So there's the STEP-HFpEF-DM trial in looking at semaglutide in patients with heart failure, obesity, and type 2 diabetes, and the STEP-HFpEF trial looking at patients without diabetes. So these two are not powered for hard clinical outcomes, but we'll look at Kansas City Cardiomyopathy Questionnaire, which is a quality of life questionnaire on heart failure, and also a 6-minute walk test, so looking at functional outcomes. So these are some of the ongoing and upcoming GLP-1 trials overall. Now, let's look at future directions with tirzepatide in patients with type 2 diabetes here. It's one of the first weekly glucose-dependent insulinotropic polypeptide, GIP, and GLP-1 peptide receptor agonist, so dual agonism. The nutrient load in the gut stimulates the release of incretin hormones, GIP and GLP-1, and of course GIP and GLP-1 signals to the pancreatic islet cells to enhance glucose-dependent insulin secretion. So you're taking advantage of this pathway with this particular molecule here. And the program that's been highlighted here is the SURPASS program run by Eli Lilly, looking at tirzepatide in patients with type 2 diabetes across a spectrum of drug combinations. So looking at it versus placebo, versus semaglutide as an add-on to metformin, with multi-drug combinations as well, looking at tirzepatide versus insulin as an add-on to metformin with or without SGLT2, looking at this again with multiple anti-hyperglycemic therapies and against just insulin as baseline here. So when we look at the A1C, HbA1c reduction across the program, going from SURPASS 1 all the way to 5 here, we can see substantial reductions in A1C, which were consistent across the trials. Looking at different doses, of course, the higher the dose, the greater the risk reduction that was noted across this particular program. As highlighted previously, the weight change seems to be rather dramatic within this particular program as well. Looking at 40 weeks, when we look at the duration up to 52 weeks, we see weight changes in kilograms of up to 9 kg or 11%, 13%, 13, 13, and 11. So substantial weight loss, seemingly independent of the types of baseline therapies that are there and the comparators to which these individuals are randomized to. And very recently published in Nature Medicine was a meta-analysis of the SURPASS program evaluating the cardiovascular risks or benefits in this particular patient population. So the composite of 4-point MACE with trends towards benefits. When we look at deaths for cardiovascular causes, MI, stroke, hospitalization for unstable angina, all of them trending in the right direction. So of course, we have to be careful. These are small studies, just with small number of events, but very interesting results. When we look at composite, including heart failure, also trending in the right direction here. And here's the sort of Kaplan-Meier curves here that show the separation of the curves happening around 60 weeks in time. And now this cardiovascular outcome trials are currently underway to evaluate whether there is truly a CV benefit within this population. So really with the multi-agonists, I'm going to really draw the attention to the tirzepatide here. And so now I'm just going to shamelessly pivot slightly. In the last few minutes here, because we have experts, I know we're running out of time, but looking at PPAR alpha modulation, we all are aware, of course, of the ACCORD study, and reminder that this was a 2-by-2 randomization with fenofibrate and statin versus statin here, and the standard glucose versus intensive glucose arm. The primary results are, of course, we're all familiar with neutral outcomes and potentially excessive risk, depending on, when you looked at the insulin, intensive glucose control, but when we look at the risk here with fenofibrate, no reduction outcomes. But very interestingly, when we look at fatal or non-fatal congestive heart failure, there was a 28% trend towards benefit here. Okay? And so the heart failure outcome was not very robustly explored, and now given that the trial database is available, we looked at it in a slightly different way. First, the heart failure events were defined as fatal or non-fatal, which is a bit old. So we redefined it to CV death or non-fatal heart failure, which is the more traditional CV outcome that we tend to look at. Okay? And we also focus our attention on the standard glucose arm, understanding that there was an excess of risk that was seen in the intensive glucose arm as well. And so when we looked at the standard glucose arm, very early separation of the curves for fibrates versus placebo for CV death or heart failure hospitalization. With a hazard ratio of 0.64, but when we look at the intensive glucose arm, almost no separation of the curves here. The p-values were very statistically significant, suggesting that there was an interaction between the intensive glucose arm or randomization to intensive glucose control and fibrates versus placebo. And we just published this results very, very recently. So the question arises is, does PPAR alpha pathway play a role actually in heart failure prevention within type 2 diabetes? We've seen the really impressive results with the SGLT2 inhibitors is this an unexplored angle upon which other PPAR alphas or similar molecules can be explored in more detail? With that, significant advances over the past decade have occurred, and SGLT2 and GLP-1s have revolutionized our approach. GLP-1, of course, may have some risk in heart failure with reduced EF, but it'll be interesting to see with the HFpEF population. There are these new molecules that hold significant promise, and of course, it'd be very interesting to see the results of these newer type 2 diabetes therapies in patients with HFpEF, and for prevention, I believe represents a truly novel frontier. So thank you very much for your